Shall we move on ahead with our next presenter for today in the morning session? And it is Dr. Sophia Merilyn George from Malaysia. And she would be presenting on the topic stromal osseous metaplasia in recurrent urothelial carcinomas forming an ossified pelvic mass, a report of an unusual case. I hope that Dr. Sophia is ready with her presentation.
Yes.
So thank you, Dr. Sophia. You're clear in your presentation and you're audible as well.
Thank you, Dr. Archana. Okay, I would just like to give a warm welcome to everyone attending the morning session, and thank you to the EPUCG for giving me this opportunity to present this case, which is very rare for me. I will be talking about a rare case of recurrent carcinoma presenting as an ossified mass. I would like to thank my co-contributors in this, Dr. P.M. Tanikachalam, Datuk Leong Menlong from Penang, who gave us this very interesting case, and Dr. Rina Rahayu Mohammed Zin from PPUKM Malaysia. I would first like to take everybody on a virtual tour of Malaysia, because I think with the current climate, everybody's travel plans have been a bit scuttled. Malaysia is this beautiful country which is located near the tropics. We do not have anything close to a winter, but we do have some wonderful biodiversity and nature here. From the peaks of Mount Kinabalu to the tea gardens of Cameron Highlands, and a wide variety of endemic species, including the Rafflesia flower and the proboscis monkey. I'm sure that if anyone comes here, it would be a visual feast for their eyes to experience this wonderful multi-ethnic and biodiverse country. I'm proud to represent my laboratory, Clinipath Pathology, which is one of the premier pathologies, private laboratories in Malaysia, in the capital city of Kuala Lumpur. We deal with an average of 20,000 histopathology specimens every year. And we were the first laboratory in public as well as private sector to start digital pathology with whole slide imaging using the Aperio software, the Aperio platform. And while it has been a wonderful journey, we are, of course, looking forward to further more information and knowledge regarding this platform. I would also like to thank my contributors at UKM, University Kebangsaan Malaysia. This university was started in 1972. It is the National University of Malaysia, specially established for the promotion of postgraduate and specialist studies, and ranked 35 in Asia. It is my great honor to be associated with my peers and mentors from UKM. Thank you. I would like to start to talk about this topic where we come across tumors which have a different or divergent differentiation. And while they are commonly seen in some other subtypes of tumors, in urothelial tumors, they are extremely rare. So to come across a urothelial tumor with cartilaginous and osseous transformation is in itself not a common entity. This component can either be malignant or it can be benign. Now, if it is malignant, it commonly occurs as a mixed epithelial and mesenchymal tumor with sarcomatous transformation. We sometimes call it a sarcomatoid carcinoma, and rarely they may have pure mesenchymal differentiation as well. The latter, where the osseous and the cartilaginous component is benign, has been given this terminology called as stromal osseous metaplasia, or SOM, which is associated with the malignant epithelial component, but the stromal component is completely benign. This is rare. A literature search found about 13 cases occurring in primary urothelial tumors and 7 in metastatic tumors. To add to this list, I would like to present an additional case of a recurrent urothelial carcinoma with an unusual presentation. I would like to highlight at the outset that the complex features of this case were compounded by the fact that this patient had visited about 3 or 4 different centers and had different biopsies done at different centers. Therefore, for us to actually get a comprehensive view of her histopathology and her clinical picture was very challenging. We only received the initial history as patient is a known case of tumor and has presented with abdominal pain and heaviness for 5 months. On receiving the specimen, we realized it had a reniform shape but looked nothing like a kidney. Then on digging further, we tried to trace back her previous reports and her history, and we found that she was a known case of urothelial carcinoma of the renal pelvis. She had undergone a nephrectomy with a bladder cuff excision in the year of 2016 and was treated with chemotherapy and radiotherapy regimens at another center. When the CT scan was performed by the radiologist, he noted that there was a lobulated, heterogeneously enhancing mass in the right renal bed and upper abdominal pelvis, which was quite large, about 8.9 centimeters by 9.8 centimeters by 11 centimeters. This mass, in addition to forming a large space-occupying lesion, also involved the adjacent right psoas and quadratus lumborum muscles with destruction of the right transverse process and the L5 vertebral pedicle. There were smaller, tiny nodules which were noted in the left lobe of the liver and in the basis of the right and left lungs, which he considered as compatible with metastasis, considering her previous history of urothelial carcinoma. So she presented, and the surgeon decided to go ahead to do an explorative laparotomy and remove this mass. On tracing her previous reports, we found a report of a biopsy of the upper calyx of the renal pelvis, which was performed in early 2016, which was diagnosed as grade 2 transitional urothelial cell carcinoma, followed by the surgery, which was a right nephroureterectomy. This specimen was an R0 resection and showed a grade 2 transitional cell carcinoma with widespread invasion of the lamina propria of the renal pelvis. In foci infiltrated the muscularis propria of the pelvis, the peripelvic adipose tissue, and the renal medulla. Foci of lymphovascular invasion were noted in the specimen. However, lymph nodes were not submitted. The tumor deposits did not breach the capsule of the kidney and did not extend into the perinephric fat. The predominant pattern of the tumor was in solid sheets and nests with an occasional configuration of papillae. Foci of necrosis were noted along with scattered mitotic figures. It was considered as a stage 3 tumor with an R0 resection as per the previous histopathological report. Following that, the patient received chemotherapy and radiotherapy and was kept on regular follow-up. When she presented in early 2020 with the mass, we were quite perplexed to see this huge space-occupying mass, which was completely bony. It just looked like a mass of bone. It had a lot of tags of fat tissue which were there at the periphery, and it I would like to show that there were a few areas of hemorrhage, a few cystic areas which were noted, but predominantly it was this dense mass of calcified bone which was extremely difficult to cut. So it weighed 506 grams. The fat was plastered over the exterior and it looked exactly almost like the shape of a kidney. It was very reniform. The total measurement was 132 by 98 by 75 millimeters, and cut section showed a completely ossified bony mass with no grossly visible soft areas. The initial sections taken were a complete transection of one cut surface, and they revealed predominantly mature trabecular bone separated by benign, loosely arranged filamentous edematous connective tissue and adipocytes. All the sections, about 14 sections, showed the same picture. When we looked at the mature trabecular bone and the higher power, they showed benign osteoblasts which rimmed the trabeculae, with a few osteoclasts noted at the periphery. There was no evidence of neoplastic osteoid, no evidence of a filiform osteoid which was noted, and all the lacunae contained benign osteocytes. No cartilaginous component was noted on the initial sections. In addition to this, the intervening stroma showed a patchy foci of necrosis, a few abundant chronic inflammatory cells, and admixed foamy macrophages with foreign body giant cells and cholesterol clefts. I would like to show the low power view, which showed extensive areas of these benign bony trabeculae, which were separated by this edematous, very loose stroma and patchy foci of inflammation. The peripheral adipose tissue, which was plastered to the surface of the tumor, did not appear to be infiltrated. Now, as we go further, extensive ossified bony trabeculae with a few cholesterol clefts in between and scattered inflammatory cells. Now, I'm sure if we saw this focus in a post-chemotherapy specimen, we would be thinking that definitely there must be a residual tumor lurking somewhere. As soon as we saw these areas, we decided to sample more and more sections, and thankfully, we managed to find scattered, isolated clusters of malignant epithelial cells noted amidst the bone. Now, these cells were polygonal to round with moderate eosinophilic cytoplasm, fairly pleomorphic nuclei with irregular nuclear membranes and coarse nucleochromatin with mitosis. Occasional atypical mitosis were also identified. Now, a few cells also showed a vacuolated and degenerated appearance. No glandular or squamoid features were seen. The stromal component was examined very carefully to look for areas of sarcomatous change. However, we could not find any sarcomatous change in the sections sampled. I would like to show the high power view of these areas, which shows these clusters of tumor cells, which with no distinctive pattern, no glandular or squamoid appearance, and fairly pleomorphic nuclei with coarse chromatin, occasional mitosis, which was scattered within the cells, and a lot of edema and extravasated RBCs in the adjacent tissue. Several foamy macrophages noted in between. Another area lurking in between this benign stromal tissue, which highlighted a similar island of tumor cells. It took an extensive search to find these epithelial islands, but they confirmed our diagnosis. We finally diagnosed it as a high-grade urothelial carcinoma occurring in a post-nephrectomy patient with extensive stromal osseous metaplasia. And we started looking for literature to find if these cases have been commonly reported. It was found that these cases are exclusively reported in urinary bladder tumors and metastasis from the urinary bladder. The first reported bladder tumor with a similar cartilaginous stroma was as early as 1856 by Ordonez. This was followed by quite an extensive series of cases studied by Lilian Essipang, who subdivided the urothelial tumors with the stromal components into those tumors who had sarcomatostroma with overt features of mitosis, pleomorphism, and mitotic atypia, and those tumors where the component was totally benign, which was considered to be due to metaplasia. Now, this subset of tumors are rare, with about 13 cases reported in primary tumors and 7 in metastatic tumors. All cases have been reported mostly in the urinary bladder. In our institute, this was the first time that we were coming across this pattern, and we were quite curious as to find out its etiopathogenesis and whether we could see it in other types of tumors. The literature search shows that the mean age range is 65 years, range of 3 to 85 years with a male predominance. Our case was a female who was 63 years old. Here I would like to talk about some of the cases which have been reported, which are very interesting. The youngest case is in a 3-year-old boy. This child presented with hematuria and on a cystoscopic examination was found to have a high-grade papillary urothelial carcinoma, which by itself is extremely rare in this age group. On sampling, there was a central nidus of osseous bone which was noted within this tumor. Another point which was noted in the literature search was that several cases were associated with prior procedures. For example, if it is in the urinary bladder, they were associated with past history of cauterization. There was one case which occurred in a case of prostatic adenocarcinoma with a bladder tumor. The prostatic tumor was treated with leuprorelin. A few cases, including the cases reported by EPUCG, post-cystectomy, post-TURP, and chemotherapy and radiotherapy. Now, I would like to highlight this seminal article, which is written on bony and cartilaginous tumors of the urinary bladder, which has an extensive description of urinary bladder tumors in adults, which contain either bone or cartilage. And a few very interesting hypotheses have been put forth regarding their etiopathogenesis, which I shall deal with later. Embryonal tumors or mixed tumors, teratomas, were not considered as they were clearly unrelated to the tumors under discussion. Another article which talks about these tumors was by Robert Young and John and Abel, which talked about unusual forms of carcinoma of the urinary bladder. This article deals with diverse microscopic appearances of all bladder carcinomas and talks about less common but most troublesome diagnostically are variants in which the cells are spindle-shaped or sarcomatoid, form small cysts, or differentiate towards trophoblasts. In other variants, the stroma has unusual features that may lead to diagnostic difficulty. These are carcinomas with pseudosarcomatostroma, osseous or cartilaginous metaplasia, or osteoclastic type giant cells. I have not dealt in detail with the primary bladder carcinomas, as I find our case fitted more with the metastatic tumors. I would just like to show this table, which shows the vast variety of locations and types of metastasis in SOM. Now, for example, the first case, which was reported by Cons, JS, and all, the metastatic deposit was in the abdominal wall, which occurred 4 years after a history of bladder carcinoma. This patient had a predominantly well-differentiated papillary urothelial carcinoma with stromal osseous metaplasia. The second case developed metastasis in the supraclavicular region, the left tibia and left femur, 2 years after radiotherapy and cystectomy for bladder carcinoma. Now, this is interesting because the sight of a bone, a long bone, can definitely give rise to a diagnostic confusion or difficulty, especially in the presence of these characteristic histological features. This was diagnosed as a metastatic papillary urothelial carcinoma with stromal osseous metaplasia. The third case, again in the bone, 14 months after the primary in the bladder. The fourth case in the left tibia. The fifth case, right femur bilateral tibiae. The sixth was a nodal metastasis. And what was interesting about this case is the patient had a radical cystoprostatectomy with lymph node dissection done. The primary tumor did not show evidence of the stromal osseous metaplasia, but this was noted only in the nodal metastasis, which occurred at that time, with a scanty foci of tumor. The seventh case of nodal metastasis, as well as in the right retroperitoneum, which is a bit similar to our case. A poorly differentiated tumor with small foci of stromal osseous metaplasia. There was no definite correlation between the grade of tumor, as all grades of tumor were noted with this histopathological feature. So what would be the possible etiopathogenesis? The article by Pang et al. Talks about the presence of scar tissue. Now, we do know that scar tissue has a propensity to metamorphose or have metaplasia into various other mesenchymal components. So they propose that the presence of scar tissue due to either a previous surgery or therapeutic modalities. For example, one of the cases had leuprorelin injection. This could contribute to creating an environment for metaplasia. Increasing local concentrations of alkaline phosphatase and proliferation of fibroblasts. In fact, in 1931, there was a very interesting study done by Huggins et al., where they actually put urothelial epithelium into an environment, in vitro, of course, and studied what minerals can be secreted by urothelium. And they found that there was an increase in the amount of calcium as well as phosphates in the medium, as well as an increased local concentration of alkaline phosphatase, which could definitely contribute to the presence or the development of ossification. This in association to the proliferation of fibroblasts, that factors like bone morphogenetic proteins like BMP1B and BMP2, which are members of transforming growth factor TGF-beta superfamily, act to stimulate these fibroblasts. These stromal mesenchymal cells transform into osteoblasts, which then result in osteoblastic metaplasia. Another hypothesis also states that there can be other transcription factors like OCT3x4, SOX2, c-MYC, and KLF4, which can generate these pluripotent stem cells which stimulate the process of osteogenesis. And of course, there's also theory which says that the tumor itself can produce a clone which differentiates towards osteoblasts. So the conditions which are considered necessary to develop this picture were hypothesized as the presence of a precursor, in this case the tumor or the urothelial epithelium or the urothelial carcinoma, and inducing agents, for example, the transforming growth factor family or transmissible factors, and a permissive environment. Excuse me. I would like to emphasize here that the presence of the BONY component does not change the therapeutic outcome. The therapeutic outcome depends on the epithelial component, which incorporates the grade of the primary tumor, the stage of the tumor at presentation, including metastasis and muscle invasion. I would like to conclude with the following points to emphasize that urothelial carcinoma recurrence presenting as a calcified mass with extensive osseous metaplasia is extremely rare. These cases have been reported in the context of usually urinary bladder tumors. Our case is rare in one, it is in a female. It has occurred in post-primary renal pelvic carcinoma and has occurred in the retroperitoneum. These ossified tumors can pose a diagnostic difficulty, especially in the lack of previous history. In our case, the patient came to us without any previous radiological findings or the previous histopathology. And it was really a diagnostic conundrum for us to find out why this tumor is ossified and what could be the primary. Similarly, for the radiologist, it is a diagnostic difficulty because these masses are heterogeneous on scanning and can mimic other tumors which can be present in that area. Another point I would like to emphasize is the role of extensive sampling. As we know, most tumors require extensive sampling, especially if they have heterogeneous areas. So if in the first look you do not see your primary tumor, please look and look again. And definitely, I'm sure we'll find the residual focus of carcinoma lurking somewhere in between these bony trabeculae. Why do we need to look more extensively at this tumor? This is because metaplastic bone needs to be differentiated from malignant stromal differentiation, which can occur in sarcomatoid carcinoma. This malignant entity portends a poorer prognosis for the patient. In cases with history of radiotherapy, an extraskeletal radiation-induced osteosarcoma, which is extremely rare as well, also must be excluded, especially in the previous cases where the metastasis in the tibia and the femur showed this picture. A malignant osteosarcomatous proliferation must be excluded on histopathology. I would like to present my references. Most of the references include this very detailed article by Lillian S. Yipang, which has extensive descriptions of these tumors in the urinary bladder. And, excuse me, this article by Young and Abel, which talks about unusual forms of carcinoma in the urinary bladder. Other than that, most of the other references are mostly single and rare cases which have been reported either on radiology or on histopathology. These are further references about these rare cases. Thank you so much. To summarize, I would like to say that we did not do immunohistochemistry in this case because the patient was not able to pay for the immunohistochemistry workup. However, an extensive and thorough search for the primary tumor with morphology and detailed chasing and workup of the previous history and radiology really helped us for the diagnosis. I thank you so much for your patient hearing. I am open to any questions.
Well, thank you, Dr. Sophia, for presenting such a rare, interesting case from uropathology section. It was really beautiful to look at your histopathology images, H&E stained sections. And the platform is open for any questions to Dr. Sophia. Well, I had like two clarifications, Dr. Sophia. Like the first one was regarding IHC. So in the end, you have mentioned that the patient couldn't afford financially for the IHC markers. So, well, I had that in my mind to ask you, like, whether did you go ahead with the IHC markers? So, well, you have cleared that. And the second was, my clarification was like, have you considered the sarcomatoid urothelial carcinoma as the prime differential diagnosis? Because they do show a lot of heterologous differentiation consisting of, it could be rhabdomyosarcomatous differentiation, or it could be osteosarcomatous transformation, or it could be chondrosarcomatous differentiation, or sometimes other different elements. So, yeah.
Yeah, thank you, Dr. Archana, for that question. Actually, when we first saw this case, our first impression was we have to look for the malignant component. So we did an exhaustive search, I think about 25 plus sections we examined. And our first impression was, why is there no malignant stroma? And why is the epithelial component not associated with any malignant stroma? Because there was a clear-cut demarcation between the epithelial component and a clear-cut demarcation between the spindle cell component. A detailed search, even for the mitosis and the atypia, was mostly in the epithelial islands. And I believe if it was a sarcomatoid carcinoma, characteristic morphology and spindle-shaped cells would definitely give us a clue as to the process. We could not find any other heterologous elements as well. We could not find cartilage. We couldn't find a muscle. We couldn't find, all we found was benign bone and this edematous stroma in between. A point about the immunohistochemistry. Normally, immunohistochemistry, we would normally do a CK7, CK20, and a GATA3.
Yeah.
Yes, and that would definitely help us in the diagnosis. But an interesting point that I found in all the literature was that a lot of them didn't do immunohistochemistry because the histology was characteristic. Histology was papillary urothelial carcinomas, and the morphology was quite distinctive, which wasn't really a problem for morphological diagnosis. In this case, we would definitely have gone ahead with an entire panel of CK720 and GATA3. Yes, especially if we found a bit more prominent epithelial component. But I think with the characteristic history and the fact that the previous nephrectomy had lymphovascular invasion, I think it really helped to contribute to our diagnosis, which ended up being a morphological diagnosis.
Right. All right. Yeah. Thank you. Thank you, Dr. Sophia, for clarifying me. So are there any other participants who want